All right, welcome to your pre-operative lecture. Listen, for this one, the exemplar worksheet is specific for this topic. So you don't want to use the generic exemplar worksheet you've been using the whole semester. Head on over to Blackboard and make sure you grab the pre-op exemplar form that will align perfectly with what we're going to talk about today. All right, today we're talking about pre-operative care. And pre-operative care means from the time the surgeon decides that a surgery needs to happen until that surgery actually happens. Now, pre-operative nurses do a lot of different roles. They serve as educator, advocate for the patient, and admitting nurse to the operative suite. But one of their main priorities is completing that pre-operative checklist. And this checklist makes sure that all the necessary documentation, assessments, physical preparation of the patient, and the education to the patient have been met before surgery starts. So let's talk a little bit about the documentation required for pre-op. Informed consent is a consent form that the patient must sign, and the components have to include the following: consent for the procedure itself, the name of the surgeon who's performing it, the reason why this would be a benefit to the patient, what the alternative options are to surgery, the consent for anesthesia to be put under for the surgery, and that includes intubation, and then consent to be administered blood products if needed during the surgery. Remember, we can't get blood consent during the surgery if the patient needs it because they'll be under anesthesia. All of these components are required, and while it's not the job of the nurse to actually obtain informed consent, it is the job of the nurse to make sure all of the components are there on the documentation. The surgeon is the one who actually has to obtain the informed consent, and they're solely responsible for educating the patient about the procedure, the risks, and the benefits. That all has to come from the surgeon directly. But the preoperative nurse can witness that signature for the consent. Remember, hear this: the surgeon is the one who must answer all of the questions and explain the consent form to the patient. But the preoperative nurse can witness the fact that that patient is signing the consent form. So if you're going in to get a consent form signed and the patient has any more questions about the procedure that were not answered, it's not our job to answer those questions. We would need to get a hold of the surgeon and have them come back and reconsent the patient. Another form that's often used before surgery is an advanced directives. Now, we talked about this way back in our fundamentals course, but the advanced directives came from the Patient Self-Determination Act of 1991 and allows the patient the right to determine who directs their care in times of emergency and what kind of care they would want. And so it defines the patient's wishes about CPR, intubation, any emergency care, and it also names a durable power of attorney for healthcare, someone who would have the right to make decisions on behalf of the patient if the patient would be incapable of making their own decisions. Time out, or a pause for cause, is something that should happen before every single surgery with the surgeon and the patient who's still awake, and the nurse. And this allows to make sure that everyone has confirmed the correct patient, that's the correct procedure, that it's the correct surgical site. Maybe they're taking off the left leg. We want to make sure they're taking the left and not the right. And that it's a formal procedure to make sure that the correct patient and surgery is identified. Before surgery happens, it's a good time to teach our patients. And patient teaching is going to include anticipatory guidance. That means what the patient can expect during surgery and during the post-op recovery. What the recovery time is going to be and what they can expect. And then there are other things that are complications that happen from surgery, specifically from the lack of mobility. And we want to teach about those ahead of time and make sure that the patient is a partner in preventing those complications. Those complications can be including things like DVT prophylaxis, deep vein thrombosis, preventing clots in the lower legs and the calves. And we can do that through SCDs, through sequential compression devices, little cuffs that actually squeeze and relax on the patient's calves to promote blood flow. We can use heparin sub-Q injections every day or some kind of anticoagulant injection every day to prevent blood clots from forming. And we can encourage early ambulation after surgery. Now, encouraging early ambulation after surgery, getting the patient up, getting them into a chair, getting them to walk is going to be a priority after surgery. And now pre-op is the time to explain that to the patient so they know what to expect. And again, can be a team member knowing that it's good for them to get up. Lastly, we want to teach our patients about preventing pneumonia because they've been intubated. They've had a breathing tube put down their throat during the surgery, and they're at risk for developing pneumonia, both due to the fact that they were intubated and also due to the immobility and the decreased desire to take deep breaths and coughs because it can hurt. So we're going to want to encourage patients after surgery to make sure that they're using their incentive spirometers and taking deep breaths and coughs to prevent complications of pneumonia. Now, there are 4 components of physical preparation that may be required before surgery. Every patient needs a good IV, preferably an 18 gauge, before they go to surgery so they can receive blood if needed, certainly anesthesia and IV fluids. Patients who are getting any kind of abdominal, intestinal, gynecologic, or rectal surgery may need to perform some sort of bowel prep. And a bowel prep is just like they do during a colonoscopy, where they take some kind of gentle laxatives or an enema, typically administered the night before at home, to clean out the bowel. The patients who are getting longer procedures or are scheduled for abdominal or gynecologic procedures may be required to have an indwelling Foley catheter placed before surgery. Prior to surgery, skin preparation is done to prevent infection at the surgical site. Patients will be instructed to shower or wash with some sort of betadine or hexachloroquine soap before they're admitted. Some surgical sites may need to be shaved before surgery. A razor is not advised because it can cause nicks in the skin, which could lead to infection. So if nurses are involved in a pre-op shave, it's done with a sterile electric razor. Finally, some medications may be required before surgery. All of these would be ordered by the surgeon themselves. Medications to prevent or reduce pre-op anxiety, things like diazepam or lorazepam, a benzodiazepine. Also, if the patient has ever had a history of nausea or vomiting with surgery, they may be given some pre-surgery medication to prevent nausea. Now, before leaving the pre-op holding area or the inpatient area, if this is being done on an inpatient unit, the nurse in charge of pre-op needs to make sure the following are completed: that all of the consent forms are completed, that the history and assessment of the patient is done, that the learning needs of that patient have been met, that any required skin or bowel prep are completed, and any pre-operative medications have been administered. So let's go ahead and get into the nursing process as it relates to the pre-op patient. First, it starts with assessment. Anytime we're doing a pre-op patient, a complete history, a medical history, and a complete physical assessment is required so we don't have any surprises going into surgery. You can go ahead and pause the slide here and review what patient history assessments are required. Here's a second page of patient history assessments. Go ahead and read these for yourselves and unpause when you're ready. In addition to the patient history, we need to take a medical history. We need to know what their full medical history is, if they have any surgical implants, any chronic conditions, and any medications that they're currently taking. Additionally, we want to know about any surgical or anesthesia history they have, any previous surgeries they've had that may have scarring that we'll have to deal with during surgery, any experiences they've had with poor wound healing that may put them at risk for poor outcomes after surgery, and if they've had any negative responses to anesthesia in the past. The anesthesiologist will also do a pre-op assessment of the patient directly. We need to do a thorough assessment of any allergies the patient has, medications, foods, medical dyes, latex, medical adhesives, environmental conditions. They all might affect the patient during surgery, and we don't want to leave anything out. We need to identify all the medications the patient's on, all home meds, any meds they've taken prior to the surgery, and be sure to include any herbal remedies and over-the-counter medications or vitamins that the patients may forget to mention. Now, because surgery patients get intubated, they are at increased risk for aspiration, and it's important that they're NPO, that they haven't had anything in there to eat or drink, to prevent aspiration. Guidelines are going to depend on the individual institution, but you're going to want to assess for when was their last oral intake. We want to get some lifestyle assessments on our patients because these put the patients at increased risk for things like poor wound healing and DVTs. So we want to assess for any alcohol, smoking, or drug use that may impact the patient negatively from the anesthesia or otherwise. As with all patient encounters, we want to screen for any history of mental illness and especially screen for any history of domestic violence at home. Remember, you don't want to have any caretakers in the room when you're screening for domestic violence or mental illness because the patients may not feel comfortable to disclose that to you. And when you're doing this private part of the assessment, if there's any conflicting medical information that the patient now discloses now that they're in private, you want to make sure that you address that with the patient and with the physician at this time. An accurate height and weight are required pre-surgery because the anesthesia that's used during surgery often uh, is often calculated based on a patient's height and weight. A complete set of vital signs is needed before surgery to make sure the patient is stable and safe to have the surgical intervention. A complete head-to-toe examination is required by the nurse pre-op. This includes all of the systems assessments. When you're looking for the cardiovascular health, you're looking at peripheral pulses, color, skin turgor, cap refill, temperature, and any swelling. You're also listening for the heart rate, the heart rhythm, and for any murmurs. When we're looking at the respirations, we're looking at the rate, depth, and rhythm of the breathing. We're listening for any lung sounds such as crackles, rhonchi, or wheezing, and we're assessing the patient's pulse oximetry. Pre-surgery, you want to get a good baseline status of the patient's neurologic function so that when they wake up from surgery, we know when they've fully woken up. And we want to check their liver enzymes and kidney labs to make sure that their body is going to be able to metabolize these medications from surgery safely. We want to perform a skin assessment, looking at things like skin integrity and hygiene. Patients who have poor skin turgor or have fragile skin may heal more slowly than an individual who's healthy. In terms of a gastrointestinal exam, we want to determine the patient's normal bowel and bladder habits pre-op. So again, we know when they return to baseline post-operatively. And then in terms of genitourinary, we want to note any indwelling catheters or any other elimination devices that the patient might have. You want to have the patient void before going into surgery, and you want to note any perineal abnormalities on their chart. Here are the diagnostics that a patient will be required to have pre-surgery. Lab tests, a type and screen in case they're going to need blood during the procedure, a complete metabolic profile that will give an assessment of electrolytes, as well as kidney and liver function, coagulation studies to make sure that they will clot safely during surgery, a complete blood count to make sure that they're not anemic to start with and that they have no signs of infection, a urinalysis, again, to show signs of infection or dehydration, and finally, a pregnancy test on any women of childbearing age. Radiologic assessments would be varied by patient. Some patients will require a chest x-ray or some kind of MRI or CT, but that will be patient specific. And then older patients or patients with a history of drug abuse will be required to have an EKG before surgery to make sure that their heart is healthy and able to handle the surgery itself. The next step of the nursing process is diagnosis. What nursing problems can we address that the patient may be going through? And for a pre-op patient, these are mostly around the lack of knowledge about what they need to know during the procedure or how the recovery is going to go, and any fear or anxiety the patient may face. Let's talk about interventions, the third step of the nursing process. Nurses are going to assess for vital signs, do a complete physical examination, look at those lab studies we talked about, determine when the last time the patient ate or drank anything, and make sure that any skin or bowel prep required for that surgery has been completed. What actions are the pre-op nurse going to take? Well, we're going to make sure that the patient has no jewelry on them. We don't need any, rings or earrings getting caught in the surgical site and getting stuck or tied, sewn back into the patient. We want to inform the anesthesia team and the surgical team if the patient has any implants, which may change the way that the surgery is completed. We want to make sure we're participating in that timeout, making sure it's the correct patient, that the correct procedure, and that the correct surgical site. And then we want to make sure that the patient has that IV, and we'll start that if they don't already have one. Pre-op nurses are going to teach those patients what to expect as part of their OR experience, and also to anticipate and how to prevent those post-operative complications like DVTs and pneumonia. That's going to wrap it up for our chat about pre-op nursing care. Thank you so much for joining me. Have a great day. See you soon.